Welcome to the Redefine Health Ed podcast. I'm your host, Dr. Katie Obright, and we're going to talk all things primary care PT. All right, hello everybody. This is episode 12 of the Redefine Ed podcast. I'm your host, Dr. Katie Obright, and today I have kind of a special, more specialty practice provider. I have Dr. Kelly Valignota, who is a sports medicine physician, and she works in a team-based healthcare setting in a large healthcare system. And I brought her on today because we were originally planning, y'all probably know that I was scheduled for to speak at the APTA Wisconsin Spring Conference. And at that conference, I was planning on doing a whole topic on multidisciplinary referral decision-making for physical therapists. So take a look in the mirror at what you're doing and say, this is a little bit outside of my scope of practice, or you're not getting the expected results that you would see with your patient. So at what point do you facilitate a referral process, and to what type of healthcare professional? So, Dr. Kelly, thank you so much for coming on today.
My pleasure. Thanks for inviting me, Katie.
Yeah. So can you tell me a little bit just about your background and what you do and what you're passionate about?
Sure. So I am a physiatrist, so physical medicine and rehabilitation physician. I know that most of your listeners are physical therapists, so you're probably familiar with us, but we are doctors of function, whether or not, the patient has had some kind of urologic insult or they have chronic pain, sports injury, pediatric disorders, and amputation, spinal cord injury. So we manage a lot of these patients' different medical parts of their specific condition, and then help. I work, as Katie mentioned, I work in a large hospital system. So I am in the gym with our therapists, which is not always the case. So it's great we really do work very interdisciplinary, check in with my patients. I can see them in the gym. Therapists also come to me and ask, questions when the patient is not progressing, which, we'll talk about. And so in terms of how I got into physiatry, initially my background is, prior to medicine, I was a professional dancer. And so
Cool.
In my dancing, so after college, I moved out to California and I danced for a couple of years with a small ballet company, and I was a dance teacher. And in that time, I started volunteering I was doing my pre-med prerequisites, because at that time I was dancing, but I was thinking I was going to go to medical school, and I was volunteering at basically a dance medicine physical therapy clinic at one of the colleges out there. So I was kind of getting treatment, but also like learning. And at some point I thought I was going to go to PT school, but then a bunch of family members were sick. I was spending a lot of time in the hospital, and that ended up kind of driving me to medicine. But when I was dancing, I realized when I would, see a doctor, they would just tell me to stop dancing. And that was, absolutely
worst possible thing to say to any athlete.
Exactly. Any athlete. And so that was very frustrating. So I kind of wanted to, be a part of the community that helped take care of performing artists. And so eventually I learned about physiatry at a dance medicine conference. And I met a couple of physiatrists and orthopedic doctors who were into performing arts medicine. And that's kind of what led me that's how I learned that this, field was a specialty. So eventually went to medical school at Touro College of Osteopathic Medicine in New York. I was non-traditional, but I also really liked the idea of learning manual skills because, again, coming from a dancer background, it just seemed like I knew that touching patients is important. And a lot of times, that's not a huge part of traditional allopathic medicine. Although it's getting to be there now, and they are learning some. I I have in the past taught some of my MD colleagues some manual type of work.
Mhm.
And I definitely try to work on some of my patients as well when I have some time to do some manual techniques. But after that, I did my internship in Chicago. So physical medicine is a 4-year residency. You do an intern year and then 3 years of physical medicine residency. And so did my residency at Thomas Jefferson University in Philadelphia. Then I came back to Chicago, University of Illinois Sports Medicine Fellowship. That was great. I was a team doctor for the women's basketball team and the men's soccer team. And then I was also a team doctor for Maine East High School. So that was really fun, very busy, very fun year. And then I was working at a large hospital system out in Seattle. And that's where I then kind of came full circle, started volunteering at a performing arts clinic out there with actually one of my mentors from when I was applying to medical school. So it was very fun to kind of work together as attendings. And then I finally moved back to Chicago and now working at a hospital system here. I do general PM&R, meaning I see a lot of just general pain complaints, but I also do sports ultrasound, diagnostic ultrasound, interventional ultrasound, electrodiagnostics. And so I'm kind of like the proceduralist and sports medicine doctor of our practice because we all have a little bit of a different focus. One of the other doctors focuses on brain injuries. One of the other doctors focuses on electrodiagnostics. One of the other doctors focuses on amputations. And then I'm kind of the more MSK sports doctor. So we have a very nice kind of broad practice. And at some point, I'm hoping in Chicago to open up that same kind of performing arts clinic that we had in Seattle. That'll take some time. That'll take a long time to do, but eventually that's the goal.
Oh, that's awesome.
So that's me.
That's great. And I love the concept of that. And I see just the future when I'm researching and reading things about primary care and about healthcare burnout and the number of physicians and healthcare professionals that are just dipping out altogether. And a lot of them are moving into, which I'm a huge fan of, and I talk about this in my podcast a lot, but the direct primary care model. But these specialty clinics are going to be more of the center for care. At least I see as insurance starts to crumble.
100%. Yeah.
We all know that that's coming. It's already happening, and it's one of the reasons behind healthcare burnout. So I have like so many. You started talking and explaining your background, and I was writing things down, and I have so many things I want to ask you about now. So we'll come back to that and like what your future goal is, but I'm curious about this, and I think our listeners would be really interested in hearing so your PM&R, that's your specialty, 4-year residency, and then you did a fellowship, et cetera, differences between that and people who have maybe a family medicine or internal medicine residency, or that's their specialty, and then they did the CAQSM. Am I saying that correctly?
Yeah. Yes.
Yeah. So differences between those two things.
Yeah. So the difference is that our primary specialty is different. But otherwise, all of us who are sports medicine boarded, we all have that CAQ. So I'm CAQ sports medicine. So it means basically that you just did an ACGME, which is kind of like the organization that oversees all residencies, and it determines whether or not a residency or the fellowship, they're like learning the things that are necessary for somebody to be called an expert in this field. And so there are non-ACGME accredited and ACGME accredited fellowships. The difference is that typically sports medicine doctors who do non-ACGME accredited programs typically have a harder time getting, not always, but they may have a harder time getting hospital credentialing or working for a professional team, just because, these types of places, or like working for a university, like a D1 school or something. So it's always good to try to do an ACGME accredited fellowship. But basically, the main difference between me and an internal medicine doctor or even a pediatric EM, basically we all learn the same thing in our sports fellowships. Some fellowships might be a little bit more. I find that most fellowships, the difference is like how much ultrasound they do. And I wanted to do a lot. And so I do a lot of ultrasound in my practice, but that's because my fellowship focused on it a lot. But essentially we're all the same in terms of the sports board and sports fellowship. You have to have passed the board in order to have that CAQ. Mm-hmm. But the main underlying difference is basically just our baseline training.
Okay. Well, so would you say, based on your setting, is there, like, could you, for example, if you wanted to act as a primary care physician for an athlete?
I could, yes. I would definitely be a little rusty, just because, for example, on a day-to-day basis, like I could do a sports physical, no problem, but I'm not always managing like cardiology. So, mm-hmm. There's, internal medicine and my family practice physicians, I definitely trust them more with managing some of these more like internal medicine type things that I haven't done in a while.
Yeah,
but,
so that's
all of us though, are, MSK experts.
Yeah, so that's one of the things that we talk about a lot in our profession too, because our profession over the past 15 to 20 years has really moved towards clinical specialties. So mm-hmm. I don't know if you know this about PTs, but PTs, there are board certifications for various specialties. Like mm-hmm. I'm an orthopedic board certified specialist. There's geriatrics, neuro, peds, women's health. So there's all of these different specialties. But one of the things that we have not been focusing enough on is just building up our ability to have general practice skills. So for example, there are a number of healthcare systems out there that are integrating physical therapists into primary care teams. And the whole purpose there would be to provide a quick, accessible visit for people with functional complaints and be able to route them appropriately to, okay, does this patient need just some general exercise, education, and can they do well with that, which is a lot of musculoskeletal pain the first time you've ever had it, or do they need something? Is it something neurologic that needs to see a neurologist or needs a neuro PT? So I think that I can't even remember where I was exactly going with that, but the bottom line. We were talking about specialties. That's right. Mm-hmm. So one of the things that I try to do in my coursework that I teach is to sort of bring the whole picture together. And one of the things that I found in my research with this is that physicians are sort of following the same track. And this has been going on for decades, where physicians really want to focus on getting into specialties. And there's not that many that are left for primary care and general practice. So much so that there's a projected loss of physician, or a physician shortage in the primary care space of like 50,000 by 2025.
Yeah, it's pretty scary.
That means that in my experience in primary care, just personally, it's been this thing where you come in and it's quick and they're like, okay, where do I need to send you? And it's not any mm-hmm. management. It's more just, all right, I need to direct referrals really quickly. So do you find that in your practice, because of this issue with primary care, that there's issues with wait times and accessibility, and just comment on any of your experience with that?
Yeah, I think in general, unfortunately, wait times across medicine are really terrible. For us particularly though, I think because so many people have pain, we see, like 90, I feel like we see like 90% of the patients in our hospital system. And so our wait times typically are about a month, mm-hmm. which is not horrible. I know some subspecialties. I mean, I've waited for my own subspecialty doctors for my own healthcare issues for, 3 months or so. Right. So, yeah, it's very tough. And, hopefully, I don't know, kids are still going into medicine, it seems like. So I'm hoping, but it's hard because, unfortunately, primary care, they're very overworked. I really feel for my colleagues. I do my best that like, if, say, for example, typically specialists, we're not supposed to refer to other specialists, but I know in my hospital system, they're so overworked that if, say, for example, I see a patient and I look at their x-ray and they're totally osteopenic, instead of just saying, primary care, please order bone density scan and refer to endocrinology, I'll just order the bone density scan, follow it up, and then refer to endocrinology myself, and then just let the primary care doctor know, just to kind of give them a little breather. But it's tough because they have so much they need to manage on a patient. Luckily for us, we can have a very specific focus in our visits.
Mhm.
Although sometimes, and I'm sure you have this too, with all physical therapists, the patient will have a million complaints, right?
Mm-hmm.
And so you kind of have to focus on one or two things, and then, as that improves, move on to the next thing.
Mm-hmm.
So it's tough, but I still, I work with medical students, and I would say at least 25% of them still want to go into primary care or pediatrics or internal medicine, which is great.
Mm-hmm.
Those specialties too, unfortunately, are like the lowest paid specialties. So,
Right.
if med students know they're going to be the most overworked and they're going to make the least money, it makes going into a specialty field feel much more lucrative.
Yeah, definitely. And one thing that's interesting in PT is as we've continued to specialize and gain more knowledge in different areas, nobody's getting paid anything differently. So people with 15 years of experience, of highly specialized experience working with Parkinson's disease, for example,
Mm-hmm.
doesn't matter. Like a new grad's going to probably get it.
Yeah,
Or when we're talking
make
about a
more.
reimbursement model,
Mm-hmm.
the reimbursement for any given, evaluation or CPT code is going to be the same. So it really, but people are still, choosing to be clinical specialists because we have very complex patients with very complex needs
Mm-hmm.
and a growing number of comorbidities. Um,
Mm-hmm.
as people age with a lot of complex health problems. So
Right.
that's just kind of the bottom line. We know, wait times actually a month is not bad at all. But wait times are getting more challenging. And one thing that I found when I worked in a larger health system was even though we're in the same health system, I still found communication to be a bit of a challenge and a barrier. So it's really nice that you're kind of right in the same space as rehab. So can you explain just what your day-to-day relationship is like with the physical therapists, occupational therapists that are there?
Yeah, I'm really lucky. I really have a lot of wonderful therapists that I'm working with. And we have very open lines of communication. So, for example, I had a patient who I saw, for back pain in clinic, and but I was also seeing her for, plantar fasciitis and tarsal tunnel syndrome. But her initial physical therapy order was just for her tarsal tunnel syndrome. But then she called me and said her back was acting up. And so I just, walked over to her physical therapist, and I saw that she was scheduled for that day. I said, you're going to be working with Miss Ray. My initial consult was for her feet, but, could you also take a look at her back? And, therapist is like, of course.
Mhm.
And so, or if they'll also come to me, they say, I've been working with this patient on their knee. It's not getting any better. They're feeling really unstable. And so, I'll bring the patient back in for a reevaluation, get an MRI if, they're having instability and mechanical complaints. So, it really kind of all depends. I will also, for example, like if I have a patient with spasticity and I'm doing Botox for spasticity, I typically like to follow up that with some aggressive physical therapy or OT, depending on if it's upper or lower extremity spasticity, just because we're going to get the most out of that Botox if we get an aggressive kind of stretching and range of motion program in with that. So I have a patient who I'm doing Botox on next week, and then we have him scheduled for PT and OT because I'm doing uppers and lowers 2 weeks after for when the Botox is, going to be starting to work. So it's just it's great. I love my therapists. They're all super friendly, really easy to work with. It's very easy to go back and forth and kind of brainstorm, even for our patients who, are not making progress. And then sometimes too, I need to refer higher up. If I'm seeing a patient and I'm thinking, this is really not musculoskeletal, this looks more neurologic.
Mm-hmm.
The more I'm starting to work with them, then they go to neurology. Or if, unfortunately, we're really not making any gains with pain management. And I do a lot for pain. I do a lot of different types of procedures, and our therapists do all different kinds of modalities. I do battlefield acupuncture. We do a lot of stuff, but if patients are not making progress, unfortunately, sometimes comprehensive pain program, pain management, if we're not, getting the patient anywhere. So, I think that's the specialist job too, is to also know, like, when you've also reached the point where you have to refer the patient out to another specialist. And that's something that has definitely come the longer I've been in attending. As a newer attending, I used to just think, I'm going to make every single patient better. And you realize that's just not the case. And you have to be okay when you come to the point where you have to say, we've done all I can offer, unfortunately, which is very hard and very humbling. But, if the patient needs more than you can offer, then you have to move them on.
Yeah, so I think that you just said something that I think every clinician in their professional career comes to. When you first come out of school and you're just getting started, it's like you feel like you have so much at your disposal to offer internally, that you won't ever have to send anybody out. Or there's people on the other end of the spectrum that like never fully gain the confidence and almost feel like they have to over refer. So finding that balance is really, really important, so that we also don't, oversaturate our referrals to neurology or to rheumatology, but using those referral sources, with good due diligence, like following referral guidelines and that kind of stuff. So now I'm curious about, so you mentioned like when you get to your limits. This is a really good segue, because the course that I was going to teach, like I had already mentioned, was on, when physical therapy, and this is, most of my listeners are going to be PTs. Physical therapists need to recognize when something not only is outside of our scope, but when we're kind of at our limit with a patient. So, and you just mentioned that you do the same thing. So I'm curious, for as a physical therapist, what are some conditions, first of all, that we should be aware of, that we might want to bring to your attention if and when we identify it? That's number one. And then I guess number two would be, at what point, or are there any conditions like off the top of your head that you can think of that you would want some sort of, eyes and ears on as we're managing a patient when we become aware of it? Because a lot of times, in my experience, most of my patients that I've treated throughout my professional career have never seen a PM&R doc. And I don't know if there's like not that many, in my experience. So I just asked a lot of questions. Speak to at least one of them.
Sure. No, yeah. So there's definitely not as many of us. And I think a lot of patients are like unclear as to what we do. I mean, even other specialists are unclear as to what we do. And so
that's PT also. We definitely have a branding and a PR problem for sure.
Us as well, because I get so many, like, even when you have a job, you're constantly getting recruited for something, and I get recruited for like psychiatry every single day of my life. But let's see.
Because of physiatry, psychiatry. Okay.
Yeah.
Oh dear.
So I think in terms of when I would say that a patient needs should have some kind of, I would typically say patients who are having like any kind of something that seems like it potentially might be a neurologic process, whether that be a more peripheral nerve process, like a peripheral neuropathy that might need to be worked up with electrodiagnostic testing, and then, address the underlying cause of that, just because, peripheral neuropathy leads to falls, leads to amputations,
Yeah.
and then anybody who's having like any radicular symptoms, because again, nerves are tough, and oftentimes we need typically electrodiagnostic testing to figure out, is there nerve damage, is there not, how bad is it acute, chronic, because all of that, especially if a patient is really suffering with radicular symptoms, we have a lot of different treatments for that, but it needs to be, we need to figure out first, is it peripheral versus central. And oftentimes it's good to have a specialist who can tease that out. And then in terms of like sports issues, I think a lot of, what we see for musculoskeletal and chronic pain things are a lot of tendinopathies. And tendinopathies a lot of times can do quite well with a course of PT or OT alone, like, Achilles tendinopathy or medial lateral epicondylitis. But oftentimes I do have patients who have chronic tendinopathy for like 10, 15 years. And the reason why a lot of times it's not getting better is when I look at it under diagnostic ultrasound is because it's all calcific, or it's just really disorganized tissue. And we do have a lot of different types of regenerative types of treatments for that. Oftentimes we even just need to break up the calcification with a needle under ultrasound. So those types of chronic-y things that are not seeming to get better with PT, any type of unstable joint, an unstable shoulder, an unstable hip, usually that signifies a labral issue, which typically I am very conservative. I never refer patients to surgery, but large labral tears, they can kind of flip in and out of the joint and start to wear down the articular cartilage, and then people develop arthritis faster. So any kind of joint instability, is typically when I would want to have the patient looked at by, sports physiatry. I'm going to shout out my specialty, but any kind of sports MSK specialist would be good. So those are like, and then again, obviously anybody who's having weakness that's seeming like it's central, especially because oftentimes weakness, we think it might be a sports injury, ends up the patient has early MS,
Exactly.
So it's anything that looks like potentially weakness that isn't pain mediated. So those are the types of things I would really kind of look out for on your physical exam. I mean, I trust my PT's physical exam like my own. You guys are awesome. And so I know that you'll, generally be able to tease out what is true weakness versus kind of pain mediated weakness.
Yeah.
So those are the types of things I would say should have a closer look at.
I would totally agree with you. Let me come back, because I know some PTs that are listening are like just going to be like, oh my gosh, all radiculopathies can be managed. They can be managed well by PTs. So let's just back up.
And they can.
Sure. Okay. So here's my position on this, especially in a circumstance where you don't have the benefit of being co-located with physicians, and you got to call, you got to wait, and sometimes people never return your calls, and it's challenging when you're sort of on an island, which a lot of us are. But for radiculopathies, one of the things that I look at, and actually there was a new paper that was published just this month that I was scanning on the issues with traditional dermatomal testing for sensory deficits, and they proposed a whole new system for this. So I need to look into that further. But
yeah, can you send me that?
I definitely will. It was interesting, and I tried to pull up, like, they had videos built into the article for what their recommendation is, and I couldn't pull up the video. So I'm definitely gonna, in fact, I'm gonna write that down so I remember to do that. But with radiculopathies, one of the things, if anybody has any pain that is referring outward that looks like it is in a radicular pattern, or is potentially referred pain that could be radicular, which are two different things, we need to be testing their reflexes. And that seems so that seems so like rudimentary, but I don't think that people are doing that often enough. And if they're doing it, they might do it at the initial assessment, but then they might not be coming back to it in a reasonable time frame, if at all. So one of the things that they recommended in this paper, as I was just briefly scanning and glancing at it, was, okay, if you do it at the initial, great. Okay, you have some baseline findings. Do it again in a week or two to see if there is any sort of progression of that patient's problem. Even if they're not having, maybe they have a little bit of pain relief, still come back to that, to your reflexes in that neurologic exam to see if they're actually demonstrating some sort of progression. And then if they are, that's when you would 100% want to include a PM&R physician or some other. If you don't have access, like a lot of my listeners are in the middle of nowhere, rural, Nebraska, let's just say, and they don't have the best access. So what's the most appropriate workup for, let's say I have a patient that came in and, was showing some signs of mild weakness, looked like a cervical radiculopathy, and some signs of mild weakness, maybe a little bit of hyporeflexia, but nothing super apparent. And then comes back 2 weeks later, says her neck is feeling better, but that her grip strength's a little different. What would be your recommendation? What should that physical therapist retest or look at? And what should they communicate to another healthcare professional if they need to?
Yeah, I think like you were saying, I think just a super comprehensive neurologic exam, you're checking peripheral nerve and dermatomal sensation, reflexes, for neck, a spurling, versus, your tunnels, your carpal cubital tunnel, make sure it's not just peripheral, and then, straight leg slump for lowers. And then if you are in a more rural location, primary care, they can order, I hate to dump on them, but if the patient only has a primary care doctor, certainly if they haven't gotten better, again, radiculopathies, typically should self-resolve, even if we don't do anything in about, 8 to 12 weeks or so. And so if they're not getting any better, or if that weakness is progressing, then even primary care to order the MRI and refer them for EMG. Just for us to say, is this process still going on, meaning acute process? Typically, those need to be treated a little bit more aggressively, especially if it's a patient who's continuing to get weaker. Or is it all just chronic and we kind of just have to wait for the nerve to recover? So the electrodiagnostic testing, even in rural places, they will still have that. And sometimes if they don't, then sometimes it is just symptom management, meaning, any doctor can prescribe neuropathic pain medication or even just, Medrol dose pack to try to decrease some of that inflammation. The evidence behind that is not so great in terms of steroid for acute radiculopathy. However, anecdotally, I find that it works. So I found the same thing. Yeah, it's different in terms of what there's evidence for and what actually works in practice, just like in everything we do.
And that's why we have to focus on that triangle of evidence, the patient. So what the patient, their preferences, their beliefs, that is a really strong predictor of how a patient could potentially do in your care. And it's something we 100%. Have to take into consideration. So that, but also your clinical expertise, which is all those like anecdotes, which it's like, okay, we don't have exact evidence that this works, but I've seen it work 100 times over. And then the evidence, of course. So taking all of those things and mashing them into a management or a management plan that seems right for the patient in front of you.
But I would still say, 60-70% of my radiculopathy patients do just fine with just PT. And oftentimes I don't even do electrodiagnostic testing until after course of PT because, it's pretty uncomfortable. And so if they're feeling better, great. If not, then oftentimes we'll proceed and then see if we need to get a little bit more aggressive.
So, and I wanted to bring that one up specifically because I do know of a case that was shared with me recently where a patient came in after a traumatic fall somebody who's younger. I think he was in his 30s, late 30s, early 40s, and came in after a fall and was having some ridiculous symptoms in his lower extremity. So much so that at the first visit of just a few days after the event, went to go see physical therapy directly, and he had foot drop. And it's like, that's something like if you've got foot drop or wrist drop or something like that, that's not
Yeah.
something that we should like hang on to very long.
Right.
So unfortunately, that case was hung on to a little bit too long, and he did not.
Yeah.
He ended up, getting an MRI like 3 or 4 weeks later, and then went right to surgery, and they
Yeah.
they decompressed it, but then he did not
Hmm.
recover his dorsiflexion,
Yeah.
which that's permanent loss of function. So
Yeah.
if we ever saw something like that, how urgently do you think that we need to act? Is that something that like we need to get them on the phone,
Quickly.
get somebody on the phone
Within,
like 24 hours?
not 24 hours, but within a week at least.
Mhm.
Ideally within a couple of days, because that patient, especially if it was a trauma, and
Mhm.
say they have like an extruded like bone fragment or something back there,
Exactly.
yeah. But again, yeah, especially if patients are having weakness like that, especially a younger patient, although
Mhm.
I'm hoping that person still recovers a little bit,
Mhm.
it may take a couple of months, but yeah, if it's really overt weakness, that needs to be addressed pretty quickly.
So let's say the physical therapist calls, I don't know, a sports medicine clinic, primary care, or ortho, or a PM&R, and let's say that they're unable to like get an appropriate person on the phone. Because I've had this happen to me a number of times. Like the clerk like puts a stop to me talking to anybody. I've had this happen to me. So let's say we can't get, and the patient tries to call on their own, and
Mhm,
they're booking 6 weeks out. In
mhm.
in that type of circumstance, what would be your recommendation for the physical therapist to do?
Oh, do you, I think it kind of depends on if you know any of the doctors in that system. If you know any of the doctors, I would reach out. If somebody reaches out to me, I squeeze patients in all the time,
Mhm.
depending on the acuity of the situation.
Mhm.
So I think that's a good point in terms of like developing good relationships with the people in your community,
Mhm.
and being just that you can say, look, this patient needs to be seen right away. And then worst case scenario, you send them to the ED,
Mhm.
because if they're seen in the ED and they have a foot drop or a wrist drop, they typically will get imaging there, or at least the ED will set them up with appropriate management. That's like
Something
the
more.
worst case scenario, because our EDs, they're for emergencies, and a wrist drop and a foot drop isn't technically an emergency, but obviously if the patient is having red flag signs, bowel bladder incontinence, saddle anesthesia, that
Mhm.
type of thing, those patients urgently should be seen in an ED. Anything, if you have a patient and they have signs of myelopathy and they're hyperreflexic on your exam, they should be seen in the ED as well.
Mhm.
So I think it's tough. That's very tough. And even that happens to me too, as an actual physician, where I'm like given the runaround within my own system, or if I'm trying to, get a patient set up with care outside. It's definitely tough.
Mhm.
But worst case scenario, in the ED, they will get imaging for overt weakness like that.
Mhm. Yeah, thank you for all of this information. So I wanted to follow
Of
up.
course.
I wanted to follow up one thing because you did mention tendinopathies too, and I'm so glad that you brought
Yeah.
that up because there was another thing, and I've known about this for a while, but there was a new paper that just came out to confirm it. Is that individuals who are on statin medications, there's some sort of interplay between statin medications and the onset of tendinopathies and potentially these tendinopathies that are more recalcitrant in nature. So I'm curious what your recommendations would be if a physical therapist was seeing somebody with a tendinopathy. At what point might they need to consider like a medication reconciliation or something that would be more managed by you?
Yeah, that's tough because, it's risk and benefit of statins And typically for most patients, they need to be on their statin for,
Right.
their cholesterol, stroke prophylaxis, and things like that.
Mhm.
So usually they're going to need to be on the statin. We're going to need to do some other things. So for example, I'm a huge regenerative medicine type person. And so if you can find somebody who is sports trained and ultrasound trained in regenerative medicine for tendinopathy, meaning prolotherapy, PRP. There's also a new thing out there called 10X.
I've heard of
These are
10X.
all, yeah, these are all ways that we can encourage these chronic tendinopathies, particularly calcific tendinopathies, to help remodel that tendon, essentially. Now, chronically torn, retorn, scarred down tendon is never going to be normal. And it may never look different under ultrasound. But I've had patients with like 10, 15 years of tendinopathy, so many rounds of PT. We do one round of one of these types of injections and they're 100% better. So it can be such a drastic change, especially for patients who really rely on, I have patients who are musicians and patients who, um, do hard labor and they rely on their arms. Patients who are athletes and they have this chronic Achilles tendinopathy. Achilles, are really hard to rehab oftentimes. A lot of times a procedure, again, I'm very conservative as much as I love procedures. Sometimes a procedure is what is needed for that, really, really recalcitrant tendinopathy.
Yeah, so a physical therapist, one who's actually doing what they're supposed to be doing, should start somebody with so we're talking more tendinopathy rather than tendonitis, should start somebody who has more of this, moderate irritability, more chronic tendinopathy. We typically would start with a loading program, and we should.
Exactly.
And it should be done with lots of patient education that like you have to get a good amount of load in that tendon to actually see a response. And then my guidance to them would be if they are not improving or if they're declining, even with low load, like even isometric type stuff.
Yeah.
My guidance would then be to go down that road, although I don't know that much about regenerative stuff, and I know that it's relatively new. So could you just give your opinion on what types of cases should we refer for consultation to see if other tendon treatments would be appropriate? Like at what point in therapy, or can you just provide some examples?
Yeah, let me see. Again, I think it's really just patients who aren't making any progress. Like, for example, medial and lateral epicondylitis is really is like my most common tendinopathy that I do this for. And they've had, 2, 3 months of OT, counter strain bracing, grasped into the tendon, and just like nothing is better. And then I'll take a look at the tendon under ultrasound. Again, it looks heterogeneous, very disorganized. Usually there's, some calcifications at the insertion. I press on that exact area where I'm seeing all those abnormalities with the probe, and the patient says, that's it. And so, if we've gotten to that point, I would probably say maybe after about, 2, 3 months of PT or OT. If we haven't made any progress after that period, or if patient is not able to do the things they need to do, they're not able to work, they're not able to play the sport they love. That's the time to potentially refer for a procedure. Now, again, there's different types of regenerative procedures, and that can be a whole other, conversation.
Yeah.
But in general, the idea behind them is that we are typically initiating an inflammatory response in a chronic issue, right? Because we're talking about tendinopathy, meaning this has been an issue for a while. And the body is no longer trying to take care of this issue, that your body's keeping you alive. So I'll give an example of prolotherapy, which is a dextrose and saline injection, and that's an irritant. And so when we inject this into, again, with like steroids, we never inject directly into tendons, but these types of regenerative injections go directly into the area that is pathologic. And we typically do percutaneous needle tenotomy, meaning we put the needle back and forth through the tendon. Obviously, this is all under ultrasound to, increase blood flow to this area. And then that dextrose and saline solution is also inflammatory. And so we're causing inflammation. And so with that inflammation, we're signaling to the body, hey, this chronic area is not chronic anymore. It's acute. So send fresh blood, which has growth factors, collagen, fibrin, to this area to try to get this tendon to remodel. And so again, this is another procedure where I typically tell patients, you're going to be in more pain than you have been in for about up to 2 weeks during that inflammatory process. So typically in these injections, there's an inflammatory process. In that period of time, especially if the patient has been taking a lot of anti-inflammatories or icing a lot, they can't do that because we're obviously causing inflammation. We don't want the process to be stopped by an anti-inflammatory. In that time period, say for example, too, if it's like an Achilles tendinopathy, sometimes I will offload them to put them in a cam boot or something for 2 weeks. If they have a really physical job, light duty if it's for upper extremities, light duty for about 2 weeks. Just because, again, that tendon, now that it's acutely irritated, it's at more risk of injury. And so I'll tell my therapist, take it kind of easy on them for about a week or two. Thereafter, there is typically a healing response. Again, even if the tendon doesn't ever look different under ultrasound. And again, if there's calcifications, if they're pretty soft, I'll just break them up. And then there's typically about a 4 to 6 to 8 week kind of healing response. And that's very variable between patients. Some patients are 10, 20% better. Some are, again, 100% better. And if, they're maybe 10, 20%, we can repeat another round. It's not like steroid where you don't want to do it that often because, again, we're just using dextrose and saline. It's not hurting the tendon in any way. Or it's not toxic to the tendon. Yes, we kind of irritate the tendon a little bit with the needle and with the solution. But again, it's a great way to encourage the body to do it, heal naturally with a little bit of help. If again, this has been a very chronic process. So that's kind of the role of regenerative medicine in these types of chronic tendinopathies.
Well, that makes a ton of sense. And I think that the bottom line with this is if you have a patient, that's not doing well or that you're not sure about, you can always either refer them for a consultation with a PM&R specialist, or what I tell all of my students and what I'm a huge advocate for is developing these good relationships where,
100%.
I have awesome relationships with physicians that I know and trust, and that I can, send them a quick text message, be like, hey, I've got this patient, this is age and, how long it's been going on, and this is the problem. What do you think? Do you think they need to see you? Do you think we're on the right track? Just real quick things that you can get the patient on the right track without having excessive wait times. And also, you had mentioned one thing about how, it's a little like how it used to be like crossing a line for a specialist to refer to another specialist. But the bottom line with that is people are having to wait a really long time to get in their primary care providers too. So if we can eliminate that delay in care, we're helping the patient. And as long 100%. As we're keeping the primary care physician or provider in the loop, I really think that the patient's the patient should be at the center and should be the priority. So for a physical therapist, it might not be primary care that might be the best option for that patient. You want to let them know what you're doing. But in the past, I have made referrals to rheumatology for patients that look and appear to be something inflammatory that I'm I could actually make their whole situation worse if I don't get them evaluated by a rheumatologist
Right.
first. Or maybe even just kind of start some things, but have a referral to rheumatology and get that process started. But if I were to just be like, okay, we'll do physical therapy, and then if you're not better, refer you back to primary care, like that's
Right.
not really helping anyone. So the bottom line
100%.
here is just kind of knowing physical therapists, occupational therapists, recognizing when it's appropriate to include a PM&R physician. And I think you gave us some really good highlights on when and why to consider that. And I'm a huge fan of all sports medicine physicians. The one that I worked with directly, it was an awesome working relationship. We were in the same place, and it was like if I had a question, I would just go over to him, and then he had a question. Sometimes he would come to me. It was just a really, really nice work setup. So just another thing to reiterate why team-based practice in a co-located setting is really helpful and really important.
100%. And just being willing to learn, be open,
Yeah.
know when you don't be embarrassed when you don't know something. Oftentimes I'm like, I learned this in residency and I should know, but I'm just going to ask my physical therapist because they're going to know and they're going to, be the expert at this point. So yeah, being humble and being able, not being embarrassed about asking questions. And, as you said, patient is at the front. And
Yeah.
so, if you can learn something to help them, then that's what it's all about.
That's great. Thank you so much. And thank you for coming on the show. If people
My pleasure.
have any
It's fun.
questions or if they want to reach out to you for any reason, how or where or when can they contact you? And I can also keep that internal if you don't want to share anything.
Yes, I will share it with you. And then if somebody wants to reach out to me, then you can give them my info.
Okay. All right. Sounds good. So there you have it. Thank you so much. Thanks for listening to the Redefine Health Ed podcast. Support our mission of getting more rehab professionals integrated into primary care by visiting redefinehealthed.com, subscribing to our email list, following us on social media at Redefine Health Ed, and taking one of our courses. All podcast listeners can save $50 on our Foundations for the Primary Care Therapist course or the Master Musculoskeletal Imaging certification by entering RHE Podcast, all lowercase, into the promo code section of the checkout page. Until the next episode, stay awesome, y'all.